All right, welcome back. In this explainer, we are diving deep into the core diagnostic challenge of Ménière's disease. We're going to figure out how to confidently identify it and, maybe just as importantly, how to rule out its most common mimics. So let's get right into it.
So here it is, the big question that trips up so many of us in the clinic. Is it Ménière's disease or is it vestibular migraine? This gets really tricky because the data shows these two conditions can actually coexist in up to a third of patients. So how do you reliably tell them apart?
Well, it turns out you don't need a whole battery of complex, expensive tests to get started. The solution is actually remarkably efficient. It really just comes down to a focused history, guided by 3 key questions, and one crucial objective test, the audiogram. So here's our game plan. We'll kick things off with that 3-question triage. Then we'll map out the key differentials, learn how to decode the audiogram's unique fingerprint, talk about smart investigations, and wrap up with the critical red flag emergencies you absolutely cannot afford to miss. Okay, first up, the most practical tool you have, the 3-question triage. Seriously, this is your secret weapon for sorting through cases of episodic vertigo right from the patient's story, and you can often do it in just a few minutes.
So here they are, the big 3. You want to ask these in order. First, duration. How long do the vertigo attacks actually last? Are we talking seconds, minutes, or hours? Second, is hearing affected? Yes or no? Does it seem to fluctuate? And third, are there any of those classic migraine features, like sensitivity to light or sound? Each answer you get is going to point you down a totally different diagnostic path.
And here's where it all just clicks into place. Look, if the vertigo lasts for just seconds and it's triggered by changing head position, you should be thinking BPV. Simple. Now, if it's spontaneous, lasts between 20 minutes and 12 hours, and it's tied to hearing loss, that is the classic signature of Ménière's. And if the attacks go on for minutes to days and come packaged with migraine features, well, the vestibular migraine just shot to the top of your list.
Okay, now that we have our triage down, let's zoom out a bit. We're going to put Ménière's side by side with its top 5 mimics. This is really going to help solidify these distinctions in your mind.
What I love about this is how cleanly it lays everything out. Just look at that episode duration column. That's your first big sorting tool. Then check out cochlear symptoms. See how Ménière's is the one that consistently has that fluctuating hearing loss, tinnitus, and fullness? Vestibular migraine? Usually no change on the audiogram. And for something serious like a TIA or stroke, you're on the lookout for vascular risk factors and other neurological signs, which are just absent in the others. So once your history is really pointing you towards Ménière's, the single most important objective test to lock it in is the audiogram. It gives you a clear, evolving fingerprint of the disease, and we're going to look at that right now. In the early stages, this is the classic picture you're looking for, a sensory neural hearing loss, or SNHL, that only hits the low frequencies in one ear. And notice how the hearing in the higher frequencies is totally normal. Catching this specific pattern is often the key that lets you move from a probable to a definite diagnosis. But as the disease progresses, that fingerprint changes. You might start to see a little dip or a notch appear in those mid-frequencies. This is also the stage where the hearing loss can fluctuate much more dramatically, which is exactly why repeating the audiogram when symptoms change can be so helpful. And then finally, you get to the late or burnt-out stage. Here, the fluctuations tend to lessen, but it comes at a real cost. The audiogram often shows a flat or a downward sloping line, which tells you there's now permanent, moderate to severe hearing loss across the board. The vertigo might finally settle down, but the hearing damage, unfortunately, is done.
Okay, now this is a really, really important point. Ménière's almost always starts in just one ear. So if a patient shows up with hearing loss in both ears right from the get-go, or if it quickly spreads to both sides, you have to stop and reconsider the diagnosis. That pattern is a huge red flag for systemic causes like autoimmune inner ear disease or syphilis, and that means urgent investigation and referral.
So let's get practical. What tests should you actually be ordering from your clinic? This next part is all about clear, no-nonsense guidance on the do's and don'ts of investigation. You're gonna love this because it's so straightforward. From primary care, there are really only 2 essential investigations. First, an audiogram for every single person you suspect might have this. Second, an MRI of the internal auditory meatus for any case with one-sided hearing loss. This is non-negotiable. You have to rule out a vestibular schwannoma. As for all those detailed vestibular function tests, the VHI, VEMPs, calorics, you can leave those for the specialists down the line. And what about blood tests? The key here is be targeted. Don't just order a shotgun panel of tests. Routine screening in a classic one-sided case has a very low yield. You only order bloods for atypical features. If it's bilateral, then yes, an autoimmune and syphilis screen makes sense. If there are systemic symptoms, check thyroid function and inflammatory markers. And of course, if you're thinking of starting diuretics, you'll need a baseline kidney function and electrolytes. And that brings us to our final and maybe most important section, the safety net. These are the absolute non-negotiable red flags that separate a routine referral from a genuine emergency that needs immediate action.
I'm going to say this again because if you take only one thing away today, it should be this. Sudden, severe, and permanent hearing loss is not Meniere's disease. That is sudden sensorineural hearing loss. It's an ENT emergency, and it needs high-dose steroids within 72 hours. Do not mislabel this.
Beyond that, you need to send your patient for urgent evaluation if they have any new focal neurological signs like double vision or weakness, if their vertigo comes with a new severe headache, or if they experience what are called Tumarkin drop attacks. Those are sudden falls where they don't lose consciousness. Any of these could signal a posterior circulation stroke, and that's an emergency. So, to wrap it all up, what are the absolute must-knows? First, use that 3-question triage, duration, hearing, migraine, to sort most cases out in minutes. Second, always get the audiogram. It's your best objective tool after the history. Third, any one-sided hearing loss needs an MRI. No exceptions. And finally, never ever forget that sudden permanent hearing loss is a totally separate ENT emergency. Okay, so we've locked in the diagnosis. What's next? Well, in our third and final explainer on this topic, we're going to dive into the complete management plan, everything from diet and medication all the way to more advanced procedural options. Thank you so much for joining us. To explore more resources for both clinicians and patients, please feel free to visit AustralianDizzinessClinics.com. We'll see you next time as we shift from diagnosis to action and build out that complete management plan.